Hi, everyone. Welcome to the last webinar of 2021. I hope we don't need any more webinars in 2022 because there won't be any health issues to discuss or health literacy issues or no one will have problems with medical decision making. I'm not sure that's going to happen, but a girl can be optimistic. So let's start. We have a really interesting topic today. I think we have interesting topics every time. Today is the 9th meeting of the webinar series on what you can do to make better choices about your health with behavioral economics. I want to present myself and where I come from for doing all this work at the intersection of behavioral economics and health. I have a PhD in psychology. I taught consumer behavior at Wharton. And right now I'm a full professor of psychology, studying medical decision-making, doing a lot of research on various aspects of how people make decisions, people being both the patients and their healthcare professionals, and looking at various aspects from just comprehension of information to digital health and really everything in between. I listed a lot of companies here that I worked with. The University of Cambridge, where I'm a visiting researcher, and my book, which we'll get to in a minute. So here it is. I brought a citation from Daniel Kahneman, and there's a word here that highlighted. There's a bunch of words that I highlighted, but the one I think most relevant for today is, he says, with a fine combination of human compassion and vast knowledge, Talia offers clear and useful guidance for the hardest decisions in life. So what do we learn? We learn that people need guidance. They can't just do this on their own, this being making good medical decisions. By good, I mean ones that benefit them, benefit their health and lead them toward their values and what they want to do with their bodies. There's another word which comes up here, and that's compassion. And that's really, really important because we're talking today about what people can and can't do and don't do. And we must remember to always be compassionate because we can get very angry at people for not doing the best for their health. I'm sure they're doing the best they can and we need to help them to do more. So the question Colette and I decided to pose for today is, why can't they just ask? And that's health literacy and health inequity. So by this, we mean people are now so empowered. Can't we just expect them to take on a more active role in their health? The answer is not always. And sometimes they need assistance. And it's our role as healthcare systems, as people who help design, who consult companies on how to design apps and anything from an app to a payment system. And we'll show you why. So what is health equity? It's when all members of society enjoy a fair and just opportunity to be as healthy as possible. Public health policies and programs centered around it, the needs of communities, can promote health equity. That sounds great and obvious, and we know that there are gaps, there are racial gaps, there are other gaps in health. So why is this happening? What is going on? And is this even an issue anymore? So I wrote, when my book launched, I wrote a bunch of op-eds. One of them was called Black Patients Matter. Here's how to help. And I wrote about Black patients. I also wrote about Hispanic patients because people are sometimes treated differently in similar situations. And that's very disturbing. That's disturbing because it's unfair. It's the opposite of health equity, and it hurts their health. It also hurts their trust in the system. And of the many, many things that COVID has taught us, that we need people to have trust in the health system for them to play along and for public health to be created. That's a definition of the World Health Organization on health inequities, and they emphasize health resources. So I'm going to talk about some things that you may not consider to be health resources, but they really are, like trust. Do I trust my healthcare provider? So Black patients have to wait longer for pain medication in emergency departments compared to white people with identical injuries. The same thing goes for Hispanics. Now, if I'm in pain and I'm African-American, someone near me is in pain and they're white and they receive pain medication long before me, why would I trust the doctor? That just seems wrong. So when we expect people to trust, we need to give them reasons to trust the system. So trust is a major commodity. And you can say, well, do I care if people trust? The answer is yes. And I write about that. And there's a lot of work on that. When people trust their healthcare provider, they are much more likely to adhere with what they tell them to do, to adhere with their medication. And that's crucial for their health. And if we don't care about their health, we do care about their health premiums. We do care about the expenses to the healthcare system. So this matters, this should matter to all of us. There are health resources like Respect. African-American lupus patients adhere much less to their medication compared to Caucasians. And it's associated with receiving fewer compassionate, respectful interactions with their healthcare providers. So something that can seem very emotional, okay, it's touchy-feely, why should I care about that, is crucial to health. And it's been shown repeatedly when people don't feel that their healthcare provider cares about them as a person, they're less likely to adhere to what they're giving them. Even though it's their own body, they should mind their health, still they feel resentful and they adhere less. So people need trust. People need to be treated with respect and with care. And people need information. Now you can say, come on, you've got to be joking when you're talking about information. This is 2021. You need information. You're on a computer right now. You have more information than doctors had 20 years ago, just at your fingertips. And that's true. But there are a couple of caveats here which we must remember. So let's see. Some information I can find online. Some information I cannot find online ever. And that is personalized information. When I ask my doctor, given who I am, given my body, given my comorbidities, given my sensitivities, how will this affect me? I need my doctor to tell me. And we see that Black people were less likely than their white counterparts to push their doctors for more information during consultations. This is a study of over 130 patients who have lung cancer. This is important. This is not some trivial piece of information, but still patients are hesitant about asking. Why? There are a number of explanations. One of them comes from sociology, and the French sociologist Pierre Bourdieu calls it embodied cultural capital. It's that feeling that you have a standing in the world, that you can ask a question and it doesn't reflect poorly on you. It doesn't mean you're stupid. It just means you are there asking and inquiring. But to have that, you need to have a sense of strength in the world. And I wonder, is it equally divided among us? Why would it and why wouldn't it be? So I looked at home ownership, slower among Black people. I looked at college, and African Americans are less likely to go to college and less likely to go to Ivy League. So this is the type of things that give people that sense of habitus, that sense of, I deserve this. I deserve to know. I deserve to hear from you, doctor. And in fact, that takes us to one of the things I developed in my book. It's a set of critical questions. I call it ask about what matters. So when you ask about what matters, and I just realized I have not made a slide on Facebook, I'm going to do that. No, I'm not going to do that. I can't figure out how. Sorry. When you ask about what matters, you ask, what are the risks? What are the benefits? And what are the alternatives? And to do that, you have to feel that you'll be able to understand the answer and that you have the right to probe your physician about it. So that's one type of thinking. Another way of thinking about it is just critical health literacy, just the ability to inquire, to say, but what does this really mean? And are you sure? And can you explain it a bit further? Or I've read online that A, B, and C, and can you please tell me what this means to me? So these capabilities are not equally divided. And the division is not just a racial one. There are many factors that go into it. One of them, for example, is how much money people have. And of course, money is a proxy and it correlates with education. So this is a study and it's a great example for two things. First of all, it tells us something. What does it tell us? Health apps, and in this case, these are health apps for physical activity, and wearables help rich people the most, study finds. Okay, so now we know. And we also know that to get people's attention, you need a sexy title. You need to say something that people will care about, because if it's the rich versus the poor, everybody cares. If it's something that has to do with race, maybe they're less interested. Maybe if you say health literacy, it's less sexy for sure, and people might care less. So what's going on here with the health apps? They work better for people from higher socioeconomic status. Why? One reason is perhaps people who have less money are less likely to be able to pursue the activities that are recommended. If you want to go to the pool, for example, well, you need to buy a pool membership, and that's expensive. If you want to go for a walk, maybe you don't have time, maybe you don't have the equipment, maybe you're tired because you were working a physical job, and that's too difficult for you. And there's another reason that we should be very concerned about, and really should be something that every developer of digital health should take into account. That's the fact that people of lower socioeconomic status tend to have lower electronic health literacy. So health literacy is the ability to read and use information. Digital electronic health literacy is the ability to understand what's happening with digital tools. This is not trivial. This is something that I've seen in my work. It can be overcome if you are mindful, if you set your mind to it, if you help people bridge that gap. Otherwise, you are giving them a digital tool and you're pretending that they can use it as well as others. And the truth is they cannot, not necessarily. It is not their fault. This is how they need health. They need information to be catered to them. And if we don't do that, it is our fault. So when there's a billing system, when there's an app, when there's anything at all that people need to use, we cannot assume that they will always be at the highest digital literacy level, because they won't. And then we're just widening the gap rather than narrowing it down. What should we do? And I wrote down institutional responses here. So this is something that people feel is very personal. They say, well, I didn't understand, or I sat there in front of the doctor and didn't feel I could ask questions. But the truth is, it's a big problem and it needs to be answered to and solved at an institutional level. And we can do things. We can take care of the readability level of medical information. So if you go online and you read something that's catered toward people at the 5th grade level, you're more likely to understand it. Also, really, regardless of your educational level, because at a time of sickness and pain and anxiety, our cognitive capabilities are not at their best. So that's one thing to do. Another is to have protocols ensuring equal treatment, by which I mean, why does my color matter when I'm at the ER? Does it matter if I'm a woman, if I'm a man, if I'm anywhere in between, and what color I am? It really should not matter, because if I'm in pain, I'm in as much pain as the next person, and we should be equally treated. So to the degree that there are protocols ensuring that, we are reducing bias. And the last thing, and it relates to people asking questions, why don't they ask, is to have defaults of allowing people to ask and inviting questions, not just saying, do you have any questions? Which means, can you leave now? But actually to say, well, I gave you a lot of information. Why don't you tell me what your take is on it, what your regime is, how you understood it, and what more you want to know? But that sounds like more of an invitation than just kind of wrapping it up with a cursory, do you have any questions? This is really the tip of the iceberg with this issue, but we are opening it up and saying we have a problem. Many people have a problem. Therefore, the healthcare system has a problem. There are ways to solve it. Let's do that. So I want to wish everyone happy holidays before handing over the presentation to Colette Edwaeds, who's a physician who agreed to be with us today, and she'll introduce herself for a moment. And this is my info, and I would love to hear from you with any questions and thoughts you have at the intersection of psychology, behavioral economics, and medicine. So thank you. And we are over to you, Colette. If you would like to present yourself as I'm uploading your presentation.
Sure, and thanks so much for the invitation. I'm really thrilled to be here. My name is Colette Edwaeds. I am a gastroenterologist. and I am the National Medical Director for Associate Health and Wellbeing at Humana, which means I'm with Humana as employer versus Humana as health plan, although I have responsibilities that span the enterprise. But most of my time is heavily focused on the Humana Associates, which is Humana lingo for employees, as well as their dependents who happen to have Humana coverage. The area of health equity is a passion of mine, and when I was at Cigna, I was actually the National Medical Director for Health Disparities, their very first. And during that time, we were the first commercial plan to actually get a Robert Wood Johnson grant in that space. Additionally, I have been a participant in the NIH Scholar Program for Translational Disparities. And we're going to talk today about health literacy because I think that this is something that is fundamental to everyone, because health literacy is not the same as your ability to read. And you can be the most educated, full degreed individual and still get an explanation of benefits and be totally clueless as to what that is. And depending upon how people speak to you in the healthcare system, the language they use, the tone that they have, you may or may not understand what they are saying in fundamental ways that can play out very, very badly. And so I'll give a few examples and stories that will go deeper in the slides, but also in follow-up to some of the comments that Talia made. So when I was a resident, in medical clinic, I had a mother come in with her child. She was someone who was lower socioeconomic status, but she had the strength and the courage to recognize the importance of taking care of herself and her child. And she had the self-assurance to be willing to ask questions. So in that particular instance, despite she had a lot of factors against her, I felt that she was probably someone who was going to have an easier trip with better outcomes than others who might be more reticent. Another example I would give is a story that was written by a contributor in the Wharton Healthcare Quarterly. I'm the managing editor of that publication, about a situation at an academic medical center. Everybody on the team had the best of intentions, and the couple spoke English, but they also had another language, and translators were not really pulled into the conversation because the medical team felt that there was sufficient understanding and sufficient nodding of the heads when explanations were given and questions were answered, and when people asked, do you have any questions? As a result of that scenario and no one really confirming understanding by, for example, asking the patient, can you tell me what you think is going to happen as part of this surgery? The patient woke up and found that she had had a hysterectomy and had no idea that that's what was actually going to happen to her. I will give an example, personal to me, just from the standpoint of looking at it from the patient view and what you can potentially be up against, even as a physician within the system, and therefore to try to put it in perspective why patients may feel intimidated, particularly depending upon the tone, the body language, the environment they find themselves in, not to mention the emotions that are running high in any medical encounter. Because you go in that door, you have a problem, and you are scared that it could be something really, really bad. And so you're kind of holding your breath throughout that visit. That's a very common scenario. So I had gone to see a specialist at a world-renowned institution, someone I had gone to before, had always been very, very pleasant with the head of his department. We had always had very good interactions. And this day, he was very different. He had gotten lab work done for me. The lab work came back normal. And so he told me, you don't have any issues. And I said to him, well, I think I do have an issue because I'm having these problems. And just because the labs are normal, particularly for these types of labs, the lab normal ranges vary from lab to lab. And what's normal for one person may not be normal for me. So then he was not really happy with my response and said to me, you're a gastroenterologist, which I am. What if a patient came to you and you tested them for hepatitis? The labs came back as negative, and the patient said, well, I still think I have hepatitis. So then I had to explain to him, this is not an equivalent comparison. What I'm talking about is something with ranges. What you're talking about is a yes or no answer. And then by this time, I was very upset by the tone he had taken because it was condescending and certainly far from what I had ever experienced for him. And so I sat there and I said to myself, do I say something? Don't I say something? Do I say something? Don't I say something? And then finally I said, number one, this physician will not see me again. And then number two, I have to say something because I need to make him aware of how he is coming across. What about the next person who comes along who does not have a medical background, is scared to death, and they have a similar situation go on? And so I said, that I was upset with what was going on. I didn't know whether he had a bad day, what exactly was going on, but how he came across. And I said, and I'm a physician, and if this is how this interaction is going, I'm just wondering what happens for patients in the same situation. So he was taken aback. I don't think anyone had ever raised that question with him before. I followed up with literature regarding the importance of the patient-physician relationship. And I also pointed out to him that being chief of the department, that medical students, residents, fellows were looking to him. And if this is what he was displaying, then other people were going to look at that as this is the way it's done and it's okay. So I've given you some situations where I could see that someone had the wherewithal just internally to probably do well within the system, and giving you at the other end of the spectrum a scenario where you can be well-informed, well-educated, know exactly what you're talking about, and still have a very unpleasant and unnecessarily so experience, and then also end up with devastating effects with a person who had no idea that she was actually undergoing a hysterectomy.
Of course.
A couple of other stories that I'll give
Can I
you.
pause you for 1 sec? I think it's a terrible, it's a great example. It's a terrible example. And it's also in a way very reassuring, because if it happened to you and you're a gastroenterologist, it really happens to everyone. It really does. And that interaction is so important. And the fact that you, being a doctor, being a specialist, had to sort of struggle with yourself, like, do I say something? Do I not say something? Is phenomenal. I mean, I made a point when I wrote the book to interview physicians who are patients, because their experiences are oftentimes very similar to yours. And I wanted it to be clear that such experiences don't just happen to someone else who is not me, who may be lower than me on various levels. It doesn't matter. Once you're the patient, all these things can happen to you. So thank you.
Oh, sure. Well, I'm glad you made that point, because what I will say, it brings up to me that as a gastroenterologist, I would have physicians who were patients, and I would always say to them, my typical approach is, even though you're a physician, and that might mean that I can use some medical lingo, I am going to assume that you probably had a month of GI training or nothing, and I'm going to treat you like every other patient. If you would like me to take a different approach, then just let me know. And there was never a single physician who didn't want to be able to just relax into being the patient and not having an expectation that they knew everything there was to know about what their problem might be, what the workup would be, et cetera, et cetera. So just giving patients that out, if you will, that there's not an expectation for whatever reason that you should know something. Another piece that comes into the whole health literacy part of the conversation, I'll give you some different examples, but some also harkening back to some of what Talia had said with regard to the trust factor. So as a medical resident, I inherited a wonderful group of patients, lower socioeconomic status. They were patients who had to take 2 or 3 buses to get to the appointments, and I had a very low no-show rate as compared to another part of my training where it was, a university setting, people much higher socioeconomic status where the no-show rate was great. But getting to the trust factor, I had a patient who people had been telling for many years that she needed to have a mammogram. And thankfully, we had a very good relationship. She trusted me. We got the mammogram, and she did have breast cancer. Luckily, we caught it early, but literally I got a page from the surgeon as they were about to take her into the OR saying, she wants to talk to you. And she was not going to go into the OR until I assured her that I had selected someone that I trusted and I wouldn't do anything but point her in the direction of someone who would really take good care of her. So trust is a really, really powerful, powerful thing. From a health equity perspective, as you see on this slide, 4 components in my mind: health disparities, we'll touch on that lightly, social determinants of health, cultural humility, which means that you don't make any assumptions about someone else and their health beliefs to start off with, and don't assume that where you're coming from is the way or the best way, which then leads to greater sensitivity, which ultimately puts you in a better position to increase your competence over time. And then the health literacy component, which Talia has already defined well for us. On the next slide, just want to make the point that equality and equity are not the same thing. So when everything is equal, everybody has the same thing. So you can see at the top that giving a bike to someone who is in a wheelchair and paraplegic is not a good solution for that person. Likewise, giving a big bike to a little boy is not going to work for him, and giving a bike that's too small for the man in the picture doesn't work for him either. Equity means that you make adjustments, really looking at who the person is, what their needs are, and you give them what they need in that particular situation to achieve the outcome that you're seeking. Next slide, please. So just touching on health disparities, which are driven by social determinants of health, and you can see some of the factors that are comprised within social determinants of health. So it's socioeconomic status, it's the built environment. Do you have some place to walk? Are you in a neighborhood that's filled with toxins? Do you have food insecurity? Do you feel safe? Do you have access to quality care? Because all of these things factor into your health and well-being, your longevity, and your health outcomes. The next slide, please. And so just to give you some examples, so Talia had mentioned previously about the digital divide. So in rural communities, in low-income neighborhoods and communities of color, people may not even have broadband. They may not be able to afford the devices that are needed for remote monitoring or even the most basic program. So to her point previously, you think that you're doing something, but you really haven't accomplished anything except to erode trust and give the person a feeling like you are totally clueless about me and my needs. Bottom, just wanted to flag for people, 10.7% of the US population on average has food insecurity, which is a very sad state of affairs. And you can see, depending upon which state you're in, it can be much, much worse than that. And then when it comes to maternal and infant death, rates much, much higher in the Black population, 3 to 4 times higher for Black women, even when adjusted for education and socioeconomic status. And when you see scenarios like Serena Williams, who ended up had a previous history of DVT, was ignored for hours and hours and hours, and she's a celebrity in a really good hospital, her life was put in danger quite unnecessarily. And so the question becomes, if someone like that can be ignored and treated in a particular way, then what hope is there for someone else without that financial wherewithal and celebrity status? Next slide, please.
I just want to ask you, so what happened with her? I mean, because she is Serena Williams. Why was she made to wait? Why was her pain belittled?
Well, I from her perspective, I think that she believes that part of it was that, clearly with regard to having a baby, it was because she was a woman. And I think clearly she thought that it was race related, and from the female perspective, it is not uncommon in the healthcare system writ large. And I'm not saying this broadly or in a blanket statement, but it is not uncommon for women to find their complaints not necessarily taken as seriously as if a man presented with the same issues. More common for people to think that their symptoms are less severe, less serious, to be attributed to something more benign, blown off to stress, blown off to hormones. So I think there's that component, and I think you've already covered nicely the reality of the disparities that can exist depending upon the color of your skin, regardless of how much money you have and if you're a celebrity. On the next slide, from a COVID perspective, and for the sake of time, because there are a lot more slides to go through, I'll just leave you with this slide that you'll have a copy of. But the bottom line is, if you are a person of color, you did not fare as well during COVID. And then you would think that since we are starting something completely new as it relates to COVID, and since we already know already there are differences in terms of gender, you would think that this would be a really great opportunity from a clinical trial perspective to get things set up the way that you would want them to be in terms of diversity of race, age, gender, et cetera. So if you go and look at COVID-19 studies at the time that I did when I was doing this presentation, that only 4% of the studies explicitly stated that they planned on using gender as a variable. So even in the face of a pandemic with gender differences that we already know about, people are not taking that into account. And so we may find ourselves potentially in another situation where things are extrapolated from one part of the population and just assumed to apply to everybody else.
Do you have ideas on how to count? It's mind-blowing. It's mind-blowing. It's not new, right? COVID is new. Disparities are not new in clinical trials. Why does this happen? Why does it puzzle the health system that there are men who are the normal person, and then there are some abnormalities like females, and you might want to include them, or maybe you don't care. How do you account for that? That is so strange.
So I think that you look at what's the gender distribution among the people who are doing research. What is the gender distribution in the healthcare workforce? Looking at some of the history for several different communities of color, the Black community, Indigenous peoples in the US, I can't speak for other countries, there's a huge trust factor. And so that means that just with, equality and equity, not the same thing. If you want to really include people, you have to do what it takes to get the diversity that we all need, because by leaving people out, that's going to mean that you aren't going to find out something that's a positive or a negative that will help someone else. And it could have all been avoided. But why this is a whole other topic in and of itself. Lots of work to be done. This is just an example of the type of disparity you can see in the quality of care by state. The other thing that I would flag for people is the approach that you may have and the recommendations you may get may vary from state to state, and the training that people get. So for example, it may be that heart disease is treated surgically in New England, but medically in Texas. And I'm not saying that that is the case, those are just examples. Another dramatic area is that in this country, people are trained very much to be focused on surgery as it relates to prostate cancer. Big picture, not at the individual level, but big picture, if men live long enough, most of them actually will develop prostate cancer, but it is not likely to be the cause of death. When you look at Europe, there's much more of a proclivity to watch unless someone has a really aggressive cancer. And the reality of the situation is, in Europe, men are not dying in droves from prostate cancer because they didn't have surgery. So you need to be thinking through and asking questions for those types of differences.
Yeah, definitely.
Next slide, please.
No, I just want to comment on prostate cancer. It's no coincidence that a lot of decision aids work on prostate cancer because there's equipoise in terms of outcomes, whether you have surgery or you have watchful waiting, which is mind-blowing. You don't necessarily know that, but they're very different treatments and they yield on average the same outcome.
So let's play a couple. I think this one really congeals the whole topic. We'll see if this will work for us. We won't play the whole video, but you'll have that link to listen to the whole video. But I think that this really will say it all.
I agree. I just need you guys to bear with me as I transfer the share to a different screen where we have the video, which is a very cool video, and we wanted you to enjoy it. Yes. No, that's us. Okay, I'll find it. I'll reopen it. If anyone has a question in the meantime, you're very welcome to ask.
And Talia, I don't know if they need to be asking in the chat or if they're muted. I don't know at this point.
Whichever way they want, they can unmute. Anyone can unmute themselves.
Okay. Okay.
It's a democratic. It's a democratic event. We are not forcing anyone to be quiet who doesn't want to be. So there we are. Yes, of course it was already open, but.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess she doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol, normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5 tablespoon and a half.
One capsule.
That's right, one capsule.
One capsule. I don't know what this is. That's
Twice?
Twice daily.
Okay, so
Okay.
so how would you take this?
When I see it's not on, I tell you how to take it. It says take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension and I've been taking care of that for a long time.
Hyper,
Mhm.
hyper.
Like you're hyper?
Mhm.
What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper? I have hypertension?
I don't know. That's what I consider it
Okay,
to being. You know.
but you know you have high blood pressure.
Mm-hmm.
Okay, but hypertension doesn't mean the same to you.
Mm-hmm.
I have a small breakfast and then I take my pills. I usually take 16 every morning. Sometimes it's difficult for me to take these pills because they say 1 tablet twice daily. I don't know if they're talking take 1 in the morning, 1 in the evening, or take 1 in the afternoon or 1 in the evening. So usually what I do is take 2 of them in the morning. And this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office and mostly if you realize the first thing you're gonna have to do if that's your first visit is fill out a form. Your heart beat real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets, and I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign, never read it, and then a couple of weeks later in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
Wow. Wow.
So I think that, and that wasn't even the story that I was referencing, but that kind of puts it all in perspective and the reason for the importance of health literacy
When they did give me
from
medicine,
the standpoint of clinicians and the system, but also from the standpoint when it comes to patients. You're going to be the only one who ever truly knows how your body feels, what you're really thinking. You're going to be the one who knows that something doesn't feel quite right, even though so far everything is coming up normal. You're going to be the one who knows I have inflammatory bowel disease, but the pattern that I'm experiencing now is different from a flare, so there's something else that's going on. So a lot of it is not just trusting the system, but trusting yourself, because you are the expert on your body and mind. Now, you're going to have consultants and other people to help guide you, hopefully, but you shouldn't diminish, in my mind, the expertise that you have. So Talia has already defined nicely health literacy for us. The health numeracy, I won't go into the details because I think the video covered that very nicely in all those examples of people not really understanding how to take their medications because they were left to interpret it in any way that they thought was correct because of a lack of specificity, which once again, things can be made more explicit and you can have the conversation of what does this mean to you to make sure that they really understand and encourage people to take notes, particularly around things you want them to do. Next slide, please. So, big picture, why should any of us care about this? So 36% of adults in the US have low health literacy. When you look at health literacy broadly, only 12% of the population falls into the high health literacy range. And you can't assume that just because you're in medicine that you fall in that category. Studies have shown that poor health literacy is a stronger predictor of health than age, income, employment status, education, or race. Now, all of those are intertwined, obviously, but as kind of a leading factor, you can, that may be a tip-off that if someone has poor health literacy, there are other things that may also be in place. And as I said, it's not the same as general literacy or reading skills. And just because you're wealthy and just because you have an advanced degree does not guarantee that you're going to have health literacy skills. I think everyone has seen forms, everyone has heard medical lingo, and they have no clue what has just been said to them. And then there's the cost. And when you calculate it out, $900 for every man, woman, and child in the US. Next slide. So what happens as a result of low health literacy? So I have, that first bullet, if you look below, you can see what that translates to. And I think for a lot of patients, when you're using medical lingo, it can seem as much gobbledygook as that. If you have low health literacy, you're going to have a greater chance of misdiagnosis. You're going to end up in the ER more frequently, greater risk of hospitalization, but typically hospitalization when things have advanced more than they needed to be. Time to diagnosis, how long you stay in the hospital, if there are adverse events when you're in there, are you really getting informed consent and really understanding, as with the person in the video who didn't realize she was overwhelmed with the form she's just signing, premature death, and then poor health outcomes. And then you also see lower rates of people seeking preventive care, cancer screening, and being adherent to medicine. So they want to take the medicine the right way. They're trying to take the medicine the right way, but no one has actually had the conversation about what the rather bland instructions may be to tell them what that really, really means and the most effective way to do it. And then you come into take it with food, don't take it with food, don't have it with grapefruit juice, etc. Next slide, please.
It's not moving. Yes.
Okay. So I think on this slide, I think we've pretty much covered why and when does it matter. So you definitely need to know what's going on for you to make the best decision for yourself. You need to understand test results when they come back so you can then ask the right questions for what the next steps are, if there are any next steps, and to determine if what you're being told is the best plan for you, depending upon your health beliefs, etc. Being able to find information if you want to start searching for yourself that's really credible and accurate, and then the ability to use technology. Next slide, please. So some of the risk factors I would add to what we've already said. Vision and hearing impairments can cause a problem, language barriers for sure, situations where the culture and health beliefs of the patient are discordant with the healthcare practitioner, which sets up a tension there. So the healthcare practitioner wants the patient to pursue one course of action, which is against their health beliefs, their culture, their religion, and then the healthcare practitioner may deem that person just as being a problem, uncooperative patient. If you have problems with cognition, And then we've talked about the impact of race, the impact of gender, and then there's the whole emotional context. So people are afraid, they forget to ask questions. People are embarrassed to ask questions because they think that people will think that they're stupid. And I totally get that, but I feel like people need to say, this could be a life and death situation. And so I'm gonna have to put all of that off to the side and worry about it later. And I've got to find out what I need to know to get what's best for me. And I'll just have to get over some of those feelings. And the more you do it, the less you feel it. And you realize that that is really being an advocate, and that really is the goal. Next slide. So for patients, advocate for yourself. If you can just go back one. And then for the system, I would say the golden rule. So if everyone within the system literally went into their job and they said to themselves with each and every patient, I am going to treat this person the way I would want to be treated. That would mean that you would make sure that the person understands. That would mean that you actually help a person get to the right place in the hospital. That would mean that if you didn't understand something, you would go get an answer because you don't want someone just making it up for you. So why would you make something up for someone else? So this is something that is free. I think that it would also be the case that it could change just the vibe in a setting and the trust within a setting and more of a feeling of being a team that's collaborative and focused on the person.
Absolutely.
Next slide.
Sure. We have 6 minutes, so.
I'm going to go through these really, really fast. We've talked about questions, given you a lot of questions there. Make sure you ask about all your options so you don't find yourself in a situation where someone is making an assumption about you because of your socioeconomic status, your race, your gender, and don't be afraid to get a second opinion. You need to know and learn and ask about basic things like your family history, risks that you have for certain conditions, preventive care services, so that you take hold of the situation and you're in control and make sure you're getting those things done that have been proven to work. The next two slides are focused on the system in and of itself. Here's some more questions for patients to ask with the TED Talk. The next two slides after that are focused on what the system can do. And I think for the sake of time and having some questions, I'll stop there because I think that at the beginning, Talia covered some of these. And we've covered I've covered some of these during the course of the slides so far. But really the bottom line is focus on the patient and do right by them.
Yes, I could not agree with you more. I really couldn't. So we would love to hear from our participants. Some of you have put in information in the chat, and we would just love to hear whatever you have to say in your own voice. And this recording will be available later, for sure. Of course, all of them are on my website. I always record because I think it's so important. The topics I cover in this webinar series are really important, like nudges and anything that has anything to do with behavioral economics and health inequities and choice. So I always have wonderful guests and have great discussions. So please go ahead.
Hi, my name is Monique. I am a global lupus patient advocate. I'm based in the United States. I just wanted to thank you both for this very thoughtful and intentional conversation. And I really like the fact that you spoke about educational experience, degree experience does not actually show what the outcome is for health literacy, and then that level of cultural humility that's needed, because I'm finding that we tell patients, ask questions, ask, but many of us have never been allowed that agency, maybe because of our ethnic or cultural background, or maybe we've dealt with traumatic situations before even our diagnosis, right? We just don't show up with our diagnosis. And so when we find ourselves in this position, we just have never been allowed to ask questions, right? To actually share the concerns that are on our heart. And so this would be such a great talk to have on a larger scale with so many other different providers, because those open-ended questions are needed. We need to feel like we're in a protected space and that we are nurtured into knowing how to ask these questions and advocate for ourselves. But it doesn't come intrinsically for all of us.
Absolutely. That's part of the reason I'm an academic and a consultant. And as an academic, you don't write books for the public audience. You just don't do that. But I felt like this was a message that had to be conveyed because it's so important. It's so hard. And, I called it, your life depends on it. It's your body, it's your health. And then if you're sitting there like that woman with the hysterectomy, being embarrassed to ask, you could get yourself in a lot of trouble. So that's a message for patients, but also for physicians and for the healthcare system. It needs to be out there in a very big way. I appreciate everything you've said, Monique.
I see a question here about a smart TV channel. So I think that could be helpful, and I'll tell you, besides the fact that it's a great idea, I think I'll give you an example for when I was in practice, in a multi-specialty group practice. And there were certain scenarios where you could go one of two ways. You could either have surgery for your problem, or you could have a medical pathway, or medical pathway up to the point where you really couldn't take it anymore, and then you went for surgery. And within that group, what we had was physicians within the group do videos about, here is what's involved with the procedure, here's what's involved with the medication, here are the pros, the cons, so the person could have the time to really absorb it and also ask questions. And people really took those to heart, and they actually did. You do these things, you don't know, will any patients actually use them? They actually did use them. And some people, in terms of which way they were headed, it did not, they stuck with the original decision. In a lot of cases, they changed their mind, but it also was a way of saying to the patient, you have agency, you have control, you have options. And we're going to talk about this together in terms of what's going to work best for you as a next step. And did we lose? Looks like we may have lost Talia.
Yeah.
So, she was there for a minute.
There she comes.
There she's back. So Talia, I think we addressed all the questions that were in the chat. I didn't know if there was more that you wanted to add to close out today. You're muted.
So I want to say thank you to everyone. The slide says happy holidays. It's not a happy topic. It's not a jolly topic, but it's an important topic. And if we take care of it, it can be happy, it can be jolly, and it can bring health. And I really appreciate everyone for joining us today to discuss it. Thank you. And thank you so much.
Thank you so much for the invitation.
Of course. Be well, everybody. Happy holidays. Happy New Year.
Bye.